Thanks everyone for dialing in. I know we're getting towards the end of the program. I hope everyone's been learning, and please feel free to ask questions at any point during this presentation or email me later on if there's anything that doesn't make sense. Radiobiology is, even for me, is a little bit difficult to get my head around. Physics is so easy, maths and there's symbols and it all kind of makes sense and it's logical. Biology is a little bit more abstract to me. So I'm going to go slowly and I'm going to try and explain the basic concepts, what we're looking for in radiobiology with brachytherapy. Some of it you may already know. My apologies if it's going too slow for you, but I'd rather go slow and make sure you get something than go too fast. Okay, so we'll just start with a quick refresher of radiobiology, and really the basic concept is, how are we killing the cancer cells when we expose them to radiation? So there are different ways that this can happen. So there's direct and indirect damage that the radiation causes to the cancer cells. A lot of ultimately the cancer cells die due to damage to the DNA within the cell itself, either through a double strand or single strand damage and breakage. But cancer cells can also die through damage to other organelles within the cell itself, so the mitochondria. So these create subtle changes at a molecular level that can have an impact macroscopically, and then a larger impact within the tumour as a whole. So really what we're looking at is killing the cells in the cancer while keeping the rest of the cells in the body intact. So we use different techniques and different concepts to our advantage in the way we treat cancers with radiation. So just looking more specifically at the direct and indirect damage that radiation can do to a cell. So direct damage is pretty obvious. So the ionizing radiation hits a part of the DNA within the cell, causing a double or a single strand break, and that cell will die. So direct damage is fairly obvious. It's the indirect damage that's a little bit more difficult to understand. So what often happens is you get free radicals created through the ionization of water molecules within a cell, and this is particularly important considering that we are composed of sort of 80 to 90% water. So then these free radicals go on to then create that double or single strand break in the cell, causing the cell to die. So there's the two different pathways that can cause cell death. So the direct damage, where the radiation itself breaks the DNA strand, and the indirect damage where the radiation causes a reaction, and that reaction then goes on to cause the break in the DNA, causing the cell death. So there used to be, I know when I went through university, we always talked about the 4 R's of radiobiology, but they have now added the 5th, which is radiosensitivity at the end. So the 5 R's of radiobiology are repair. So this is how cells who have subtle damage to them can actually repair themselves in between doses of radiation. We have redistribution, where cells that are in different phases of their cell cycle, so cell goes through a different cycle as it multiplies and regenerates. So when you irradiate a bunch of cells, there's a redistribution of the phases of the cells that are still alive after the round of radiation. There's repopulation. So during the course of treatment, cells will start to regenerate at a different rate depending on how much radiation they've been exposed to and the period of time in which they're undergoing the radiation as well. There's reoxygenation. So the presence of oxygen allows the radiation to be more effective in killing cells, and during different irradiation cycles, the cells will be more oxygenated at certain periods, and so that will affect whether a cell dies when the radiation is directed to the cell. And then the last one is radiosensitivity. So this is sort of an intrinsic genetic environmental sensitivity factor that will determine whether a cell is more sensitive to the radiation than another cell as well. So we'll look at all of these in a little bit more detail. So the first one is repair. It is difficult for an individual cell to deal with damage to the DNA. So if it's been damaged either directly or indirectly from the radiation. So what damage can do is cause temporary or permanent blocks in the progress of cells through the cell cycle. So if you block the progress of cells through the cell cycle, the cell will eventually die without regenerating, or I'm trying to think of without splitting and dividing and creating cells. That's what I'm thinking of. The damage to the cell's DNA can also cause a mutation to that particular cell, which then creates a secondary cancer risk. So obviously cancer cells, mutated cells that rapidly divide and multiply. So if you deliberately mutate a cell by damaging its DNA, you can then cause the risk for secondary cancers as well. So that's something that we have to think about. Treatments that have a high dose rate, so things like HDR Brachytherapy and also external beam radiotherapy, where the dose is delivered in the space of several minutes rather than several hours or days. There is an assumption that there's no cell repair occurring during radiation. This is in contrast to low dose rate brachytherapy, where the treatment time and the exposure time is so long that you actually have to account for individual cells repairing whilst they're also being irradiated at the same time. So this can be significant, particularly for very low dose rate brachytherapy treatments. And so we need to account for this when we're looking at how much dose we're going to give our patients and how long the treatment's going to go for. So this is just a little bit of a schematic about what can happen when a cell has its DNA damaged. So you've got your ionizing radiation coming in, and you've got your direct or your indirect damage, damage being done to the DNA. So what can happen in that case is you can have permanent cell cycle arrest. So the cell won't repopulate, it won't divide, won't multiply, and eventually the cell will die. You can get what's called apoptosis, and this is activation of a sort of a, we call it like a cellular death protein within the cell itself, and this will cause the cell to die. So that's another thing that can happen as part of the ionizing radiation. Another thing that can happen is called a mitotic catastrophe. So this is where the damage causes the cell to die as it's dividing. So it won't die until it starts to divide because you've damaged the DNA and the dividing mechanism that it has. So that's another way that you can have cell death. The rest of the ways you can have it is you've got minor damage to the DNA. This can then have either complete repair, so the cell recovers from that minor DNA damage, it continues to grow and multiply. This can be a good thing if it's healthy tissue. Obviously, if this is cancerous tissue, this is not a good thing because we're trying to kill the cells. If you have damage of DNA, you can also have what's called incomplete repair. So this is where, again, you might have that mutation within the cell itself that will cause cancer cells, new sort of cancer cells to form. You could also have that incomplete repair that might then turn on that cellular death protein and cause apoptosis, or a mitotic catastrophe could occur from that the incomplete repair of that cell damage that happens during irradiation. So this book, Practical Handbook of Brachytherapy, I don't know how I got a copy. I think I got a free copy from a lector at some point. I've tried to find an electronic copy so that I could provide it to you all, but I can't seem to get my hands on it. But I do know a couple of the authors, so I'm going to contact them and see if I can get an electronic copy to put up on the website so that you can all access it, because it's actually a really nicely written book that explains things in a really easy to understand way. So I've stolen a few of their slides, a few of their graphs from the book. So what this curve is showing is if you have a single dose of radiation, how many cells will survive depending on the amount of radiation that cell is exposed to. So obviously in a single dose, if you expose your cells to 6 gray of radiation in a single dose, a lot of the cells won't survive. If you fractionate that dose, so if you give that 6 gray over 2 fractions, you'll find that a larger proportion of cells will survive. So that's sort of how you'll see different cells surviving through the effect of fractionation. And that's what we use to our advantage in radiation therapy. So repopulation is the next R in radiobiology. So what happens is with each fraction of radiation, you get a decrease in the number of surviving clonogenic tumor cells. So clonogenic cells are cells that have the ability to repopulate, to divide and multiply. So obviously cancer cells dividing and multiplying at a much higher rate than normal cells. So these are the sort of things that we have to look for. And what clonogenic cells can do is once they've been irradiated over a period of time, they can actually start to increase the rate that they divide and multiply. So increasing the rate of proliferation. So what you tend to see is, depending on the tumor type that you're looking at and the cell type that you're looking at, around about 2 to 6 weeks after you start radiation therapy treatment, you'll see the tumor cells start to multiply more quickly than they have before. So depending on the cancer cell that you're looking at and trying to treat will depend on how long you've got to actually effectively treat that cancer. So this is part of the reason why we have fixed timeframes in which to treat our cancers, because after a period of time, that cancer cell division and multiplication starts to ramp up and it becomes more difficult to kill all the cancer cells in a single dose of radiation. So that's something that we really need to consider as part of the radiobiology and part of, how many fractions do we treat with and how long overall treatment time should be for different cancer types. So as the tumour is repopulating, if we increase the overall treatment time, so if we increase the treatment time from 2 weeks of treatment to 6 weeks of treatment, we actually need a higher dose of radiation in order to achieve the same kind of local control, so the same kind of cell killing over time. So that's the effect of repopulation and why it's something that's important we have to consider as part of radiation therapy. So the next R is called redistribution. So different cells all cells have a cell cycle. You've got different phases. So there's a G1, G2, an S phase, an M phase, and they're just different parts of what's going on in the cell. So the M phase is where you actually have your cell division, and then things like the G2 phase is where it's the cells preparing to divide and multiply. And so during these different phases of an individual cell cycle, they have different radiosensitivities. So cells that are in the S phase are actually the most radioresistant. So it takes more radiation to kill cells that are in the S phase than it does, say, for cells that are in the G2 or M phases, which are the most radiosensitive. So the sensitivity of a cell is increases from the G1, G2 to the S phases. So what happens if we irradiate a bunch of cells? So all the cells are going to be in different phases of the cycle. If you have a big jar of cells and you irradiate them with radiation, those cells are all going to be in different parts of their cell cycle. So what you'll find is if you irradiate those cells, all the cells in the radiosensitive phase of the cycle will die. And the cells that are left are going to only be in certain phases of the cycle. So what you'll see is those remaining cells will now be in sync with each other. And so if we continually irradiate them, we're more likely to get all the cells in that jar now being in the radiosensitive phase and we can kill them more effectively. So again, that's where fractionation comes into play. So by irradiating more than once, we're more likely to catch those cells in a radiosensitive phase of their cycle as well. So redistribution will make the cells more sensitive to fractionated treatment compared to a single dose. So again, that's where our fractionation schedule is useful in killing the cells. Excuse me. So this is just another graph that shows the different radiosensitivities of the different parts of a cell cycle. So you can see in the G2 and M phase, we need far less radiation to kill the cells than we do in the late S phase. Okay, so that just shows you that even the same type of cells will have different radiosensitivities depending on where they are in their cell cycle. So the next R is reoxygenation. So we've already sort of talked about our direct and indirect damage to our DNA, and indirect damage is probably more common than the direct damage. Okay, oxygen cells, now water molecules in cells and in the body are much larger than the DNA strand that you would break in a direct damage. So if we've got more oxygen in our cells, there's more oxygen available to create these free radicals that will then damage the DNA of a cell. So that makes sense. So it's a little bit like our cell cycle. So if tumors are radiated with a single dose of radiation, those cells that are the most oxygenated will be more radiosensitive, and so they'll be killed. And the cells that remain will be the ones that are hypoxic, that have less oxygen in them. Again, using fractionated treatments, so those hypoxic cells that remain after a fraction of radiation, they actually become more oxygenated for a brief period of time after they've been irradiated. So if we hit these cells with a first fraction, kill off all the cells that are highly oxygenated, those that remain actually become highly oxygenated for a period, and then we hit them again with radiation, and we have a greater chance of killing those cells off as well. So it can result in increased sensitivity of the tumours to radiation. And particularly because cancer cells are rapidly dividing highly metabolic cells, they're the ones that have these fast cell phases. They're the ones that are taking up a lot of the oxygen in the body. So we can really target our cancer cells really nicely and use this effect to our advantage. And the oxygenation is actually one of the major reasons why the fractionated treatments leads to an improvement in the therapeutic ratio. So your therapeutic ratio is where you've got your tumour control probability curve and your normal tissue complication probability curve, and you've got that sort of area in the middle where the risk of normal tissue complication is small and the chance of tumour control is high. So that's your therapeutic ratio. So the oxygenation effect is one of the big reasons why fractionated treatment works so well, because cancer cells are highly metabolic and do have a lot of oxygen in them. So again, this is a curve that will show you the difference between a cell that has a lot of oxygen in them will require a lot less radiation to kill than a cell that doesn't have a lot of radiation in it. So this red line is your oxygenated conditions, and this blue line is where there's a lack of oxygen. So again, you can see you need a lot more radiation if a cell isn't highly oxygenated to kill the cells. The last one of the 5 R's is radiosensitivity. So here we look not only at a cellular level, but we look at tissues and the individual as a whole in terms of their radiosensitivity. So at a cellular level, there's obviously different sensitivities of cells to radiation, and we can measure that in vitro. So we'll put cells in a petri dish and we'll irradiate them and we'll see what happens. But then we need to think of the bigger picture and look at individual tissue sensitivities. And the radiosensitivity of tissues can vary due to their functional organisation. So if they're a serial organ or a parallel organ, different organs have different levels of cell proliferation and the ability to undergo apoptosis, where you turn on that cell death protein. And different tissues will have sensitivity variation due to early and late effects of radiation, and I'll cover that in the next slide or so. But then you also have to look at the individual, so the individual person. And so each individual will have a different radiosensitivity from one person to the next. Some of this is for genetic reasons. So there are, genetic markers that will show that a person has a predisposition to certain types of cancers and certain types of radiosensitivity. And obviously this can also be influenced by lifestyle factors as well. So, smoking and different things will affect whether cells proliferate, whether cancer cells proliferate more quickly than with other people. Okay, so now we start to sort of get into a little bit of maths. And so what we as physicists try and do is we want numbers. We want to figure out how this all works. We want to apply a formula to get all this right so we know how it works. The problem is radiobiological modelling is really complex for all of those reasons I've just talked about. There are so many different things that will cause and affect how a cell dies from a dose of radiation. So, but we try. All we can do is try and predict what's going to happen. So we often simplify a lot of our radiobiological modelling using the linear quadratic model. So I'm sure you've all heard of this before and seen the basic cell survival equation, where the number of cells surviving after a given dose of radiation is given by this equation. We've got our alpha and beta, which represent the radiosensitivity of the cell. So the alpha beta ratio is a measure of how sensitive a cell is to fractionation dose. So a higher alpha beta ratio will indicate less sensitivity to the sparing effect of fractionation. Okay, and they'll have greater early effects. So you'll see more damage more quickly if you've got a higher alpha beta ratio. So just to expand on that a little bit, so what we see is many tumours are often what we call early responders to radiation. And so they'll have a high alpha beta ratio sitting around about 10 gray. So when we talk about an early responder to radiation, it means that the changes that you see in those cells happen very quickly after exposure to radiation. So if you think about, you've got a big massive tumour in your cervix and you give it 45 gray radiation, that tumour will shrink significantly in that period of time that it's being irradiated. At the same time, you've got healthy tissue around that tumour that's being irradiated to pretty much 45 gray as well. But it doesn't seem to shrink or to be damaged in the same way that the tumour is. And this is because healthy tissue is what we often call a late responder of radiation. So it has a low alpha beta ratio of around about 3 gray. So what we'll see is that any damage caused to those healthy tissues or those tissues with a low alpha beta ratio will happen later on, further down the track. So when you'll start to get your tissue necrosis, or you'll get your stenosis, or you'll get radiation effects, they'll happen later in those tissues. And this is a big reason why fractionation is so useful in killing tumour cells. So our tumour cells are responding really quickly to all this radiation. The healthy tissue is responding less quickly. It's repairing more quickly. So this is why we use fractionation. It helps kill the cancer cells, but it also helps spare the healthy tissue. It's perfect. Okay, there are some tissues that show early reactions to radiation. So for example, skin has quite a high alpha beta ratio. And this is why you'll see most patients will have some kind of skin reaction whilst they're undergoing their external beam radiotherapy treatment. So, classic case is your breast patients. They'll start getting skin reddening and soreness before you've even finished treatment. And that's because the skin has this high alpha beta ratio, and it has it's an early responder to radiation. The converse of that is that we have some tumours that have a low alpha-beta ratio, and one of those is prostate. So the alpha-beta ratio for prostate cancer has been in debate for quite a few decades now. The original thinking was that prostate cancer had an alpha-beta ratio of 10 gray. The thinking these days is it's sitting more around the 3 to 4. So it's actually a late responder. So those tumours that have that low alpha-beta ratio means they could or they should possibly receive higher doses of radiation per fraction to compensate for being a late responder to radiation. So these are the type of things that we consider when we start to look at prescribing systems and fractionation schedules. So this is just a graph that kind of shows the differences. So the top part of this graph is for tissues that have a large alpha-beta ratio. So most of our tumours, certainly our gynecological tumours, have a large alpha-beta ratio. So you can see that if you give the radiation dose in a single fraction, or if you use multiple fractions, the amount of cell killing is kind of the same. It's not very different. The big difference comes from these tissues with a small alpha-beta ratio. So these are now our organs at risk. So this is our bladder and our rectum and our sigmoid that lie all around our gynecological cancer. And you'll see that if you increase the fractionation schedule, so decreasing the dose per fraction, increasing the number of fractions, you'll get a lot less cell killing for those types of treatments. So this is quite a nice graph that kind of shows you the difference about how the fractionation effect is really great at sparing tissues with a small alpha-beta ratio, whereas increasing the number of fractions doesn't make a huge difference to our tumours. So this brings us on to now figuring out, okay, we know we need to fractionate some treatments and but we now need to figure out exactly how much dose we're supposed to be giving our patients in how many fractions we're going to be treating them. So this is when we start to look at a thing called a biologically effective dose, or BED. And this now starts to try and account for how the tissue is going to respond to the radiation based on the dose per fraction, the total dose that the tissue is going to receive, how long, so the overall time of treatment, so whether it's 2 weeks or 4 weeks or 6 weeks of treatment for a particular tissue based on their alpha-beta ratio. So this equation here is what we use to calculate the biological effective dose. So here we're looking at the number of fractions and the dose per fraction, the overall treatment time in days. So this does take into account breaks in treatment, so weekends. So whilst they might be given 25 fractions, that 25 fractions is actually over 35 days, not 25 days, because you've got the weekends in between as well. So we do take that into account when we look at our overall treatment time. This T delay is the time from the beginning of treatment to that onset of rapid repopulation that we talked about a few minutes ago, where I talked about, 2 to 6 weeks after you start treatment, the cells start to more rapidly redivide and multiply. So we take that into account in the equation. And that's also taken into account in this K value here, which is sort of an equivalent dose of radiation that will account for that repopulation, so in grays per day. So what the biologically effective dose is a little bit like a virtual dose, and this is producing a biological effect, the same biological effect as what we call our physical dose, so what we call our prescription, but with a dose rate that is infinitely low. Okay, this will make more sense in a few minutes when I talk about a equivalent dose. But so just keep in the back of your mind that this biological effective dose is with an infinitely low dose rate. Okay, so here's our equation here. And when do we use this? When do we actually use the biological effective dose? What are we using it for? It's actually really useful when you want to equate doses with different fractionation regimens. Okay, so if you want to say, I'm going to treat my patient with 2 grays per fraction, or I'm going to treat my patient with 4 grays per fraction. How does this match up? How many fractions do I need to give to make it biologically equivalent? Okay. In external beam and HDR brachytherapy, we usually simplify that biological effective dose equation and remove the last term of the equation. And this is because we're assuming that there's no cell repair during irradiation. Okay, this is because we're irradiating these cells in the order of minutes rather than hours and days. We're assuming that the time between successive fractions is long enough that any sublethal damage that is done to the cells has been repaired. So this is a minimum of 6 to 12 hours. So this is why we don't give 5 fractions of radiation to a patient in a single day. Okay, this is why we might give a maximum of 1 or 2 fractions in a day, because we need to account for this sublethal damage repair. Otherwise, we don't know how much dose we're giving our patient. It's really difficult to work out. The other assumption, which is a little bit wilder and a little bit more out there, is we're assuming that the overall treatment time, so the whole time it takes to give all of our fractions, is close to or shorter than the time for that onset of rapid repopulation. So for cervix cancer, that time for rapid repopulation is sitting at around, depends which paper you read, which book you look at, it's somewhere around the 20 to 30 day mark. And so if we're treating cervix cancer, we already know we tend to give, 20 fractions, 25 fractions of external beam, and then they have a couple of weeks of brachytherapy. So that's certainly a lot longer than that 20 to 30 days, but we do make an assumption that that overall treatment time is still close to that time before you start to get that rapid repopulation going on. Okay, so like I said, the biological effective dose is really useful to compare the radiobiological effect with different fractionation regimens. So just as an example in this table, we've got a couple of different doses per fraction. So we've got 1.8 gray in one scheme, 2 gray in another, and 4.5 in another. So the total physical doses are almost identical. So we've got 45 gray total dose, 46 gray total dose, and 45 gray total dose. So our physical doses are almost identical. If we look now at our tumour, which has a high alpha beta ratio of 10, the biological effective dose, you can see for those 3 different schemes is quite different. So, and all of them are a lot higher than what our physical dose is actually prescribed to. So if we treat with a 1.8 gray per fraction dose, or if we treat with a 4.5 gray per fraction dose, the biological effective dose is over 10 gray different, even though you're giving the same physical dose. It's hard to get your head around. I still struggle with it, but this is a useful way of sort of comparing apples and oranges to see where you're sitting. If we look at our normal tissue, you can see that the differences are even bigger. Okay, so the biological effect for a 1.8 gray fraction is 72 gray total. For a 4.5 gray fraction, it's 112. So it's significantly different. So again, here you can see the sparing effect of having multiple fractions. So if we have less fractions, like our 4.5 gray scheme here, we're effectively giving more dose to our healthy tissues because it's got that low alpha beta ratio. So it's got that late effect situation going on. If we increase the number of fractions and hence reduce the dose per fraction, we actually reduce the dose or the biological effective dose to our normal tissues. So again, this kind of shows the sparing effect that the fractionation can give to our normal tissues. You can see that there's not a big difference in dose to our tumours with our high alpha beta ratios, regardless of the fraction size that we're using. The big difference is sparing our normal tissues. And that's really what we want to be doing. Okay, so I just want you to note again that the simplified equation that's at the top of the page there is only suitable for external beam and HDR brachytherapy. So if you're using LDR brachytherapy, or if you're using HDR brachytherapy where you've got an extended irradiation time, because I know some of you have quite old sources that aren't very hot. So if your irradiation time for your patient starts to drag into the hours as opposed to, let's say, under an hour, you do start to need to incorporate repair during the irradiation. So you then start to need to incorporate this additional term into your biological effective dose calculation. And so you'll see this equation come up in the spreadsheet, which I'll go through with you. Hopefully you've all been sent out the spreadsheet. So you'll see the difference in the calculations that we use depending on whether you've got long or short treatment times. So whilst we say you can use this top equation for HDR brachy, if you have a source that is quite cold and your radiation times are stretching into the beyond an hour or so, you really should start to incorporate that repair component into your biological effective dose as well. Okay, so a lot of you will have heard the term biological equivalent dose. Okay, so biological effective dose is not the same as biological equivalent dose. Okay, it's really important to remember they're quite different. They're quite different things. Okay, so what happens is we've got these biological equivalent dose values. So we've, as you could see with the 4.5 gray per fraction, 45 gray total dose, we've got this biological effective dose of 56 gray or whatever it was. What does that mean in a clinical kind of sense to our patient? What does that number even mean? So what we have is a more practical approach by converting these biological effective doses into an equivalent dose that's delivered in 2 gray fractions. Okay, so this is a dose that you would get if your doses were delivered in 2 gray fractions that would kill the same number of cells. And this is a really useful tool because 2 gray fractions have been the gold standard of treatment for a very long time. So we have a lot of clinical data and evidence of reactions and tumor responses and healthy normal tissue responses, a lot of evidence based on treatments given in 2 gray fractions. So we can use all of that evidence for all the other fractionation schemes that we choose if we convert those fractionation schemes to an equivalent dose in 2 gray fractions. I hope this makes sense. It's hard to get your head around. Okay, so by giving this equivalent dose in 2 gray fractions, you can get a better indication of how you're going to control your tumor and how your normal tissues are going to respond based on this standardized dose per fraction. Okay, does that make sense? Okay, so how do we equate this 2 gray equivalent dose, so EQD2, I'm sure you've all seen that written somewhere before, to our biological effective dose? So here's our equation for our biological effective dose. Okay, so this part of the equation 1 plus d of alpha beta is called the relative effectiveness component. Okay, so what we do is we then do a ratio. So to get our 2 gray equivalent dose, we divide our biological effective dose by the relative effectiveness value for a 2 gray fraction. Okay, so it's your biological equivalent dose divided by 1 plus 2 over alpha beta. So here's our equation here. So for tumours and early reacting tissues with our alpha betas, we're always just assuming it's 10 gray. It might be 9.8. We're just there's a lot of assumptions we make in radiobiology. But what you'll see is our EQD2 dose for an alpha beta of 10 is your biological effective dose over 1.2. So they're not the same. So your EQD2 is not the same as your biological equivalent dose. Depends on your alpha beta ratio. So for a late reacting tissue, where we have an alpha beta of 3 gray, we have the EQD2 for that particular alpha beta is the biological effective dose over 1.67. So they're different. Okay, so biological equivalent dose is not the same as a biological effective dose is not the same as the equivalent dose. They're different. I just wanted to stress that. So if we go back to our 3 schemes that we were looking at before with our 1.8, 2 gray and 4.5 gray per fraction, if you remember, our biological equivalent doses were sitting at sort of 50 to 60 gray. If we now convert those back to a 2 gray equivalent dose, you can see obviously if you're giving your doses in 2 gray per fraction, the EQD2 is going to be the same as the physical dose of 46 gray. For slightly lower dose per fraction, we're going to get a slightly lower EQD2. So it's going to be a slightly lower, you'll see a slightly lower response for our tumours. If we increase the dose per fraction, we'll get a slightly higher increase in the EQD2 value. Again, looking at our normal tissues, the response is less marked than it is for the BED. So for a 1.8 gray, we've now got 43.2 gray EQD2 for our normal tissues. At a 4.5 gray dose per fraction, we've got a 67.5. So the differences are a lot less than what they are if you're looking at the BEDs. So when do we use the 2 gray equivalent doses? So we use our biological effective dose if we're comparing 2 different fraction regimes for the same patient. But when we want to use our 2 gray equivalent doses is when we're trying to determine whether doses to organs at risk or total dose to the tumour are within the tolerance values that we know from clinical evidence. Okay, that we know, if your bladder receives over 80 gray, that's bad. If your tumour receives more than 90 gray, that's good. So this is when we use our 2 gray equivalent doses. We use our 2 gray equivalent dose when we're combining 2 different fractionation schemes for a single patient. So this is the classic example of when we've got external beam that's 1.8 or 2 gray per fraction, and our brachytherapy, which might be 5, 6, 7, 8 gray per fraction. We want to know what the total dose is to our patient. This is where we use our EQD2 doses. And so to calculate the total dose that our patient gets, if we've got these 2 different fractionation schemes, you simply add the 2 EQD2 values together. So for example, and this would be a typical sort of brachytherapy scenario, if you have your external beam, you've got 25 fractions, 1.8 gray per fraction, an EQD2 dose of 44 gray. With our HDR brachytherapy, we might give 3 fractions of 8 gray per fraction, 24 gray physical dose, but 36 gray EQD2, which gives us a total of 80 gray EQD2. So we're then saying our tumour is getting effectively 80 gray in 2 gray fractions. For our organs at risk, it's the same scenario, but obviously the EQD2 values are going to be different. Okay. So again, there's a lot of assumptions we make in radiobiology. So looking at our EQD2 values, the assumptions we make is, again, that there's no cell repair during our external beam or our high dose rate brachytherapy if our radiation time is in minutes. Okay. Again, we're making the assumption that the time between fractions is long enough for any sublethal damage to be repaired. Again, we make the assumption that our overall treatment time is close to the time of onset of rapid repopulation. There's a couple of other things that we make an assumption for, particularly adding the external beam and brachytherapy components together. So we assume that all volumes for high dose rate brachytherapy receive the full external beam radiotherapy dose. So that's saying we know our tumour gets 45 gray external beam, but we also assume that our bladder gets 45 gray, that our rectum gets 45 gray, that our sigmoid gets 45 gray. So we make an assumption that everything in our brachytherapy treatment volume has received the entire external beam dose. Okay, it's an overestimation, but that's much better than underestimating. So it means we're on the conservative side of dose in these cases. A couple of the other assumptions we make: in a fractionated treatment, the volumes represent the same anatomical position throughout the entire treatment. So this is a static situation assumption. So we're assuming that the dose to the bladder for the first fraction of brachytherapy, where that high dose is on the bladder, is in the same position for the second fraction of brachytherapy. So if you look at your, say, your D2cc doses for your bladder, those D2cc doses might be in a different position in the bladder for each fraction. But again, we're assuming the worst, and we're assuming that in each fraction, those D2cc doses are actually occurring in the same position on the bladder. So again, we're overestimating the dose to our organs, which is a good thing. Okay, the other assumption we make is the same absorbed dose and the time dose pattern of external beam and high dose rate brachytherapy produce the same biological effect. Okay, now this is a fairly big assumption, particularly considering the dose and dose rate inhomogeneity in brachytherapy. So if you think about even your tumor's not getting a uniform dose. So it's not getting a uniform dose or being exposed to a uniform dose rate. Okay, the inner part of your tumor that's close to your source is getting a much higher dose rate, much higher dose than the outside edges of your tumor. So in all of this, we're kind of assuming that that doesn't make a difference. Okay, but in reality, it might. It's hard to tell, but it's too hard to figure out at the same time. So we just assume that this is what. Okay, so if we look at how this works in practice in the clinic, we have these dose constraints. So I think these have been sent to you guys before. So these are the dose constraints that we use are based on our EQD2 values. So these constraints come from the EMBRACE-2 protocol. So the EMBRACE study has been going, it's been led by a group in Europe. It's been going for quite a while. So there was Retro EMBRACE, which was the first study where they looked retrospectively at data. There was the first EMBRACE study, which they started gathering data, but it was a non-prescriptive type of study. And then the EMBRACE-2 study is actually very prescriptive. So they're telling participants what doses they should be giving, both for external beam and for brachytherapy. So it's a really useful, I guess, protocol that internationally everybody refers to. It's available freely. If you Google EMBRACE-2 cervix, you'll be able to download their protocols, and it's a very useful tool. So internationally, this has kind of become the standard for cervix treatments, and these dose values have become the standards. So these EQD2 dose limits have come from the EMBRACE protocol. So the assumption that they make in these dose constraints is you're using 1.8 gray per fraction for your external beam. And these values have been calculated by Adam and myself for 3 fractions of high dose rate brachytherapy. I think the table we might have sent out might have 2 tables if you're doing 3 or 4 fractions of brachytherapy. So it just depends on the resources you have. So I know a lot of departments in the US treat 4 fractions of brachytherapy. Where I am in Australia, we treat 3, and that's fairly standard in Australia. So there's no reason, if you can treat patients safely with fewer fractions, then that's okay from a resource perspective, as long as you calculating the EQD2s properly and giving the right doses. So I'm going to quickly jump across to the Excel spreadsheet, which hopefully you all got a copy. I don't know if anyone's run through this before, if Dan or Derek have run through this in previous weeks, but this is just our EQD2 calculator for our cervix patients. So you can customize this to whatever works for your department. This is just what we've come up with that, you know, we thought might be helpful as a starting point. So I put some information in here from a patient in my department, just so I've got some numbers to show you, otherwise it doesn't make sense. So in my department, what we aim to do with our brachytherapy treatments is we give 8-gray coverage of our high-risk CTV. So we try and get our 8-gray isodose line to cover our high-risk CTV. That's just the way we've always done it. You can, whatever works for your department is fine, and we treat in 3 fractions. So this particular patient had 45 gray total dose in 1.8 grays per fraction, and they didn't have a nodal boost. Sometimes we do a nodal boost up to 50.4. This particular patient didn't. And so this patient in their 3 fractions had a high risk, quite a small high risk CTV size of 26 cubic centimeters. And by the 3rd fraction, that volume had shrunk as well down to just under 20 cc's. So you can fill in all the information that you like to do. I haven't filled it all in. This is just to show you how it works. So you then go on to the next tab where you've got your plan A. So plan A is your standard plan. So this is your starting point for your treatment plans. So this would be normalizing to point A's, getting a nice pear-shaped dose distribution, and really no optimization that's gone on. So this is just your standard plan. So you put down your track value. The purpose of track is really just to give you for me, it gives me a sense of whether I've gone too far with my optimization. So sitting beside my planning computer, I have a graph that is what I arranged that my track value should be compared to the size of the tumor that I'm trying to cover. I remember the first patient that we went to treat with an MR-based plan, and we could actually see our tumor for the first time ever. It was super exciting. The problem was this patient had a really large tumor, and there was no way we could treat it with the applicator that we had. But our radiation oncologist was so excited he could see the tumor, he just wanted to cover all of it. And so we pushed the dose and we pushed the dose and we pushed the dose to try and cover our large tumor. And our track value just went off the charts. So for me, the track value is a sanity check that I haven't done anything too extreme with my optimization. So that's what I use the track for. So your SK is just your air coma rate at the time of treatment. So these are some of the doses. So our starting point is we normalize our point A's to 8 gray per fraction. So our high risk CTV was getting 100% coverage of that 8 gray. Our D90 doses were quite high. So I can tell just from looking at these numbers that we actually had a very small high risk CTV. So by pushing the doses out to point A, we were over covering our high risk CTV because these numbers are so big. So you manually put in your D2cc, your ICRU point for your bladder, whatever values you can fill in. The more you can get, the more useful this is going to be for you. You've got your vaginal wall points. These are quite new. We've only really started to consider dose to the vagina in the most recent ICRU publication, which came out 2016. So before that, the vagina wasn't really considered too much. And I must admit, it's only been the last few years that I've started to think about it in my plans. So I'm still learning and tweaking about what it is I can do to reduce the vaginal dose. Before that, I really didn't think about it a lot, I must admit. So the ICRU RV is the traditional ICRU rectal point, but they're now calling the rectovaginal point. So it's exactly the same point, it's just they've renamed it because they feel it's also a good indication of what the vaginal dose is going to be. So you fill in all these numbers for your standard plan, and then they'll automatically, on this spreadsheet, calculate what your EQD2 doses are. So you'll see from our external beam, the EQD2 doses for our external beam are up here, and then we've got our equations for our EQD2 biological effective doses as well. Okay, so we've got our standard biological effective dose formula, and then we have the biological effective dose formula where our treatment times have extended out beyond an hour. So in the spreadsheet, if you want to account for the repair half-life of cells, so if you do have those really long treatment times beyond an hour or so, you would change this box to yes. So you would just choose yes, and that would change your EQD2 calculations. You'll see if you change it to yes for treatment times that are less than, say, an hour, hour and a half, the numbers will change, but they're not as accurate. So I wouldn't change that value to yes unless your treatment times are more than an hour, because it's actually less accurate if you change it to yes for treatment times that are less. So you'll see our EQD2 doses have automatically been calculated. So our 8 gray to our point A has now been converted to 12 gray EQD2. Okay. So all of those are automatically calculated in this spreadsheet using these equations. We then do the same thing, so we optimize our plan now. So we get our plan and we start to tweak dwell positions, dwell times, manually or inversely or graphically, however you choose to do it. And then we can add our optimized plan values in. So you can see now with our optimized plan, our point A doses have dropped down to 7, less than 7 in some cases for each individual fraction. We're not quite getting 100% coverage of our high-risk CTV, but that's fine. 95% is what you want to aim for, so we're certainly meeting that in all of our plans. And our D90 doses are a lot less. So we've cooled the plan down. You can see our track value is lower, so our plan overall is cooler than our standard plan. And again, our EQD2 doses for our optimized plan are automatically calculated in the next spreadsheet. The important thing to notice is this condensed summary plan, which is probably really hard for you to see. Try and blow it up. So this summarizes all of the main evaluation criteria into a single table, and it adds each individual fraction as well as the external beam and gives you a total EQD2. You'll get your traffic light system, so you get your green is good, red is bad for each of these individual factors. So you can see, if we ignore this 44.25 because there is no data in there, so it's not going to pass. But you can see in our plan A, our bladder and our rectal dose is too high. Okay, we've exceeded the EQD2 dose tolerance for our bladder and rectum. When we go to our optimized plan, we've managed to pull the rectal dose much lower, almost halved it, which is great. And our bladder dose is sitting on the edge of being, it's within tolerance, but it's just sort of in that area where you go, we can make it a little bit better. But obviously at the time, when we treated this patient, the oncologist decided that they were prepared to risk that bladder dose for that patient to get the coverage we needed for their tumour. So this last page is a really nice summary that will show you the difference between your standard and your optimised plan, just to show you that you are making some improvements to the plan with your optimisation. So you should have all been sent a copy of this spreadsheet. If it doesn't make sense, if you need help using it, please email me at any point. Happy to help. So we'll go back to this. Sorry, I've gone so long. The last thing I wanted to just quickly talk about is what happens if a patient misses a fraction. So sometimes there are things that are unavoidable. So, you know, talking with you guys in Egypt who have had the problems in your department, I'm sure there are patients that are not turning up for treatment, and they may not turn up for several days. So we should account for that in our treatments and in our prescriptions if we possibly can. Okay, so there are multiple reasons why patients might not turn up for treatment or might not have treatment. So, and as we've learnt, for certain tumours, prolonging that overall treatment time can affect the treatment outcome because it's going to affect the biological effective dose. Okay, so what can we do? How can we compensate for those missed treatments? So there's a couple of different options that we can look at. What we can do is try and keep that overall treatment time to what it originally was by treating on weekends. So obviously you're maintaining the dose per fraction, the number of fractions, overall treatment time. The biological effective dose is the same. Obviously that's a big ask for most people, not only for the staff, but also for the patients to turn up on weekends for treatment. So often that's not feasible. So that's a problem. What you could also do is try and keep that overall treatment time by treating a patient twice a day rather than once a day. So the benefit of that is, again, you're maintaining the overall treatment time, the dose per fraction, and the number of fractions. What you might see as a potential problem is you might see a possible increase in normal tissue complications, particularly if you need to treat lots of bidaily fractions. So if a patient has missed 10 fractions and you need to treat 10 days twice a day, you will probably see an increased risk in that normal tissue complication probability. Another option you can do is keep the overall treatment time by increasing the dose per fraction. So the benefit of this is you're maintaining your overall treatment time, so you're not worried about that repopulation effect that goes on, but you have a reduced number of fractions. Okay, the problem with this is it isn't suitable for a high dose per fraction treatment. The linear quadratic model starts to break down, and it's just not really suitable. If they've missed so many fractions that the dose you have to prescribe per fraction starts to shoot up beyond 5 gray, really our radiobiological calculations start to break down at that point. So there's a potential problem there, depending on how many fractions they've missed. So the other alternative is to deliver extra fractions with an increased dose per fraction. So we'll extend the overall treatment time, but we'll try and compensate for that radiobiologically. The problem is that this may affect tumour control probability, and it may affect the dose to the organs at risk. So there are ways around it. None of them are ideal, but we can use our radiobiological understanding and knowledge to try and keep the impact as minimal as possible. So if we recall our radiobiological effective dose equation, and if we want to account for a delay in the overall treatment time, we'll need to use the expanded equation, which does take into account overall treatment time and the time to onset of rapid repopulation. So just as a worked example, if we've got a patient and they've missed their last 5 fractions of external beam therapy for the cervix for whatever reason, so let's just say the original prescription was 25 fractions, 1.8 gray per fraction. Let's just think about the tumour to start with our alpha beta ratio of 10. So we're going to assume the time for rapid repopulation for our cervix tumour is 28 days, okay? And the K value to compensate for repopulation is 0.7 gray per day. to go into this equation. Okay, so the original biological effective dose, so the original prescribed treatment to the tumour was 49.6 gray, so 1.8 gray per fraction, taking into account our alpha beta ratio, 49.6. Okay, so if we treat those final 5 fractions the week later, so the patient's missed Monday to Friday, they come back the following Monday and have those final 5 fractions. So the overall treatment time is now 44 days instead of 33. So we've extended our overall treatment time by 7 days. Using the equation above, what we get is the biological effective dose. The actual treatment to the tumour is 44.7 gray. So the biological effective dose has been reduced by 5 gray, just by extending that treatment time out by 1 week. Okay, or it's 4.9 gray less than prescribed. Okay. So you could think about it and go, well, can't we just increase the dose per fraction to compensate for that 5 gray biological effective dose that we're missing? So if we wanted to do that, we have to now determine what the dose per fraction should be in order to get the same biological effective dose of 49.6 with our overall treatment time of 40 days instead of 33. So we need to work backwards and find what D would be. So in this case, for the last 5 fractions, you'd need to give 2.49 gray per fraction for the last 5 fractions instead of 1.8 gray per fraction in order to have the same biological effective dose to our tumour. Okay. However, if we do that, we're also going to change the biological effective dose to our normal tissue. So if we now look at our original prescription biological effective dose for our tumour was 72 gray using an alpha beta ratio of 3. If we now change our dose per fraction for 5 fractions to 2.49, so we have 20 fractions at 1.8, we have 5 fractions at 2.49, our new biological equivalent dose or effective dose is 80.4 gray. So by increasing the dose per fraction in order to keep our tumour dose the same as what we've prescribed, our normal tissue doses have been increased. So we've increased the risk to our normal tissues. And this is where the trade-off starts to happen. And you've got to start to think about what it is, what risk you're prepared to take. Are you willing to risk reducing the normal tissue complication rate at the expense of your tumour control probability? Okay, so it all becomes very difficult. I'm glad I'm not an oncologist that has to make this decision because ultimately it does come down to them. But as physicists, we should understand this information so that we can help in a discussion with our oncologists coming to that decision. Some departments I've worked in, they've asked the physicists to do all these calculations. In other departments I've worked in, the oncologists do all the calculations and we're left in the dark with it all. I think a mixture of both is always a good thing. I think it's important as physicists for us to understand this as well, so we can be actively involved in the conversation. So to keep the original tumour prescription would result in an extra 7 gray biological effective dose to our organs at risk in this scenario. Okay, so I just want to stress again that this kind of calculation and dose compensation can't be applied to high dose rate brachytherapy treatments with high doses per fraction. Okay, all those equations that we look at, they really start to break down at much higher doses per fraction because we just don't have enough data, enough clinical evidence in order to be able to apply those formulas to make them work for high doses per fraction. Okay, so what happens if a patient misses a HDR brachytherapy treatment? How do we compensate for it? I must admit, we just give the same dose per fraction at the earliest possible time that we can treat that patient again. So we've never increased our dose to compensate for a missed brachytherapy treatment. So, but there may be other departments that do. It's not what I've experienced. So just a final note of caution. So these calculations should really only be used as guidance and not as absolute rules for clinical decision making. So, you know, in that example we just used, a patient missed 5 fractions. You know, we can give them information and data, but we shouldn't necessarily rely just on that information and data to make the decision. It needs to be looked at as part of a much bigger picture. Okay, and this is because all the formulas that we're looking at have a limited field of application. And there are so many assumptions that I've gone through for each of these scenarios that may not apply to all circumstances. So again, you know, if you've extended your overall treatment time and the rapid onset of repopulation has already happened, then what do? What value do you use for the time for rapid onset of repopulation? Again, depends what publication you look at. Even for cervix, I've seen publications that say 20, I've seen publications say 25, 30, 35. So, you know, again, this is why it should all be used as guidance, but not as absolute. So I just recommend a cautious attitude when considering this radiobiological stuff, particularly for missed fractions. Certainly the EQD2 doses in the Embrace protocol have become international standard, and there is a lot of clinical evidence based on those EQD2 doses now. So I do rely quite heavily on those, I must admit. So there's just a couple of references. And like I said, I'll contact the authors of that practical brachytherapy book just to see if I can get an electronic copy, and I'll put it up on the website as well, because it's quite a nice, easy to read publication. So thank you for your time. I don't know if I didn't stop for any questions. I don't know if anyone had a question. Oh, how can you get the K value? So that K value again has just come from publications. So I'll try and see if I can find that particular publication where I've got that value and I can send it out. But again, that K value comes from a publication, and it will be different from one publication to the next. So I think the value I used in that demonstration was probably an average of 3 or 4 publications that I've used. But I'll see if I can find a couple of references where we get specific values for that. So, are there any questions from anyone else? No? Well, please feel free to email me at any time. I know it's a lot to get your head around. I still get confused by it all. But I highly recommend looking up the Embrace 2 protocol. It does explain it really nicely. It does go into some of the radiobiological stuff as well. So it's a nice publication to read. All right. If there's no questions, I assume we say good night, good morning, good afternoon.
Thank you so much, Claire. This was great.
Not a problem, anytime. Nice to see you all.
Thank you, Claire.
Thank you very much.